Welcome everybody to tonight's webinar. I am super excited for all of these amazing faces via Zoom that have joined the meeting tonight. So I'm still kind of paying attention to people that are entering the waiting room and letting them in, but we're at about 600 people, I think, right now that are in this webinar right now. I think more are coming. I know a lot of other people signed up because they want to see the recording of this. So it's man, it's humbling, to be honest with you, to see all the great reactions for this. We put this out on social media, just kind of threw it out there that we were going to be able to do a presentation like this, especially these times with a lot of us maybe not fully at work or a little bit more home or restricted with what we're doing. I think it's really neat to be able to do educational offerings like this and to be able to present via Zoom and the internet like that. And I think it's really great that we're at the point where this has become something that we're doing a little bit more often. So again, I am super humbled by all of you that decided to join me here. I know a lot of you are maybe new to me, or I'm new to you, right? I know there's a lot of new faces here that probably haven't seen me present or seen me speak or don't know much about me. So I think, again, that's amazing that you have given me your 8 p.m. time slot on a Monday night, because that is a sign that you believe in me. So thank you so much for joining me. Tonight, we're going to be talking about the 5 keys to the evaluation and treatment of the shoulder. And I hate to simplify things too much, but my presentation style and what I've been doing a little bit more lately with some of my presentation is to do more of like these keys, right? Than some of the specifics that we do. Because I think when you go with a broad approach, and you'll kind of see in this presentation as we go through this, that what we're gonna do is almost like simplifying the complicated. And I think that's one of the things that people tell me more often than not, is that they really enjoy my teaching style where I take complicated things and I make them more simple. So if there's one thing I'm proud of with my education style, it's that. And that's what I try to do with a presentation like this when we kind of talk about these main keys. Now, we can nitpick about a rotator cuff tear all night, right? And that's a whole nother presentation, right? We could do that for hours, to be honest with you. But I think the biggest bang for our buck and the biggest amount of things we can do is make sure that we're covering these 5 keys. So we're going to talk about probably one of the most complicated joints in the body, and we're going to simplify it to 5 main keys. And believe it or not, I don't want to like over promise here, right, and not be able to deliver this, but these 5 keys are going to be super important for how you take care of most shoulder patients. Believe it or not, it's going to be very applicable to a lot of different shoulder people that you work with. So it's almost like the low hanging fruit, which is a phrase that I use all the time. I'm really trying to find the low hanging fruit here. And I think if you pay attention to these 5 keys, you're going to help the vast majority of shoulder patients. Now, don't get me wrong. Is there always going to be a goofball? Is there going to be somebody that comes in and throws you curveball? Of course, right? But that's complicated. It's a complicated joint, and we're complicated things. We're humans, right? So there's always going to be some things that are a little bit more complicated. But again, I really think during this presentation that the biggest bang for our buck is going to be in these 5 key principles. Okay. So for those that are new to me, right? I'm Mike, right? I'm Mike Reinold. Obviously, you probably figured that out by now if you signed up for this. But I know a lot of you are new to me. Maybe you didn't follow me on social media before this presentation, or maybe you didn't know I had a website or a podcast or all these other things that we've been doing. But I'm a physical therapist. I'm an athletic trainer. I'm a strength and conditioning coach, and I'm actually one of the odd ones that actually have worked in all those different settings too. And it's not just like letters after my name or different things, but I've actually kind of worked in those settings. And I'm gonna talk a little bit about my background before we get into like the big chunk of this, because I actually think it's applicable to the material. Right? It's not that trust me, I hate talking about myself. It's not the fun part of a presentation, right? It's much better when somebody gets to introduce you, but we don't do that with webinars, right? So, but it's kind of applicable to how I got here, right? And the point I'm at with what I do with shoulders has a lot to do with what I've been through. So again, I'm a PT, athletic trainer, strength coach, kind of worked in all those environments. I'm from Boston, right? So a lot of people probably know that about me already if you follow me already. I got my undergrad degree in physical therapy from Northeastern University. I actually one of those people that graduated with a bachelor's degree. So I've already dated myself, and I've already a lot of people think I'm old already, and I guess it's nice to be youthful, but I got my PT degree over 20 years ago and just had a bachelor's degree. But I went back to school and I got my doctorate in physical therapy from the Mass General Hospital Institute of Health Professions. And really, I just wanted to make sure I had that DPT because I wanted to continue to teach in the future. I think that's really important. So it's kind of why I did that. But while I was also in physical therapy school, I also became an athletic trainer. And one of the neat things that I did after I graduated from physical therapy school was I went and did a fellowship at the American Sports Medicine Institute down in Birmingham, Alabama. So you're probably already picking up on that, right? I'm from Boston. I moved to Alabama. That was a huge culture shock, right? You can kind of guess, right? No offense if anybody here's from Alabama, right? But it was a different kind of vibe moving down to the South, but it was an amazing opportunity. So I got to work with some of the best people in sports medicine and really not just sports medicine, but just high level orthopedics and everything from professional athletes to the total shoulder replacement, right? So my mentors, Kevin Wilk, Dr. James Andrews, Dr. Fleissig, who's the biomechanist at ASMI, they've done so much for me to kind of teach me all these different things about the shoulder. But it's funny, right? Most people know Dr. Andrews there in the middle, right? He's probably the most famous sports medicine surgeon in the world, right? He does like most of the Tommy John procedures in baseball players. He does all the NFL players. Heck, he does like WWE stars. Like he's the guy that does all the famous people, right? But what people don't really know about Dr. Andrews is that he also does like a total shoulder replacement and a rotator cuff repair in somebody from his town, right? So he's not just like the surgeon to the stars. So we got to work there, and we got this huge learning environment at ASMI where we're all doing research. We're all doing both clinical, biomechanical, and even like cadaveric type research, a bunch of different things that we were doing at ASMI while we were also working in the clinic. So we're super proud that we call ourselves like clinical researchers, not just like in a lab all the time, but we try to find some of the problems that we're dealing with in the clinic and then try to solve that answer ourselves through some of the research. So I've been using this information and this thought process, and I've been doing this for so long. Here's a great picture of me from Alabama, and that's actually Lenny McCreena. For those that don't recognize him, we were both little kids back then, I think. It's kind of funny, kind of looking at that now and seeing how young we looked right here. But the point I'm trying to make here is that we've been working with shoulder patients. We've been doing so much for shoulder rehab for so long that we've seen a lot of different things. And over time, what it showed me was that there are many different types of injuries and diagnoses and even surgeries that we might see for a rotator cuff repair patient. But believe it or not, they're not all that different if you kind of just put them all together, right? Like they don't necessarily differ that much. So if you put together some of the principles, you can really figure out a lot of what we're doing with shoulder patients. Okay. So I say all this because essentially I'm telling you I'm old, I guess. I think that's the biggest thing behind all this, right? This was before I had Lasix. This is when loose, baggy clothes were more in style, right? It was a little bit different at the time, but we've all progressed since then. So while we were there, again, we started to do a lot of different things. Like we published things. We did a lot of our research where we would actually write journal articles. So we've done tons of publications, tons of research questions. One of the things that I always teach my PT students is the power of asking why. And one of the things I always say is that I really think it's super duper important that you always have a rationale behind what you do. And I kind of said that here, because if you can look at some of my papers, I use that, my clinical rationale. We even use that in the title of some of our manuscripts. I want you to always know why you're doing everything. So for me, when it was, 20 years ago, we were trying to figure out what we wanted to do for, let's say, exercises for the shoulder. If we couldn't find the answer in the research and the literature ourselves, we would actually do the research study. And we published a bunch of different studies on how to best rehab the shoulder and do stuff like that. So it was pretty cool to be able to do all of that together. So tons of publications, wrote a textbook on the athlete's shoulder again. So we've done a bunch of different things, which again is pretty neat for our shoulder background. I was really fortunate, and this is kind of why I got into physical therapy, to be honest with you. I got an opportunity to work in pro sports, and specifically Major League Baseball. So I actually went and worked with the Boston Red Sox. So if you remember from the beginning of my story, I'm from Boston, right? So this is actually kind of like your dream job, why you go to school, is to work with the Red Sox. So it was pretty cool. But again, I got this opportunity partly because I worked with so many shoulder patients. And I think that's one of the main things with baseball, especially for all like the athletic trainers in the crowd. Baseball's a different sport. It's not a lot of like neck injuries, big trauma. We're not running on the field and splinting people, right? It's usually coming in and looking at somebody's like fingernail, or sometimes I have to apply some very sophisticated sunscreen, right? You can actually see I'm putting a lot of effort into that for some reason. But it's a different type of athletic training, right? But what we did was we focused a lot on the shoulder, and we did that now at the professional sport type level. So great experience. Obviously got to win a World Series. That was pretty cool, right? You get to kind of see a little bit of the rewards of that. I actually currently work for the Chicago White Sox, so I change colors. I always kind of tell everybody that doing the laundry with all those Red Sox, everything was getting pink. So I was like, I'm just going to switch to the White Sox just so we can have better laundry, right? But it's hard on a webinar. I can't like hear you laugh. So just pretend, like make it very obvious in the video. So that way I don't feel as bad. But again, got to do this experience with baseball players. But more importantly, what we did is we opened up our own center outside Boston called Champion PT and Performance. And what we do here is a combination of physical therapy and sports performance training, and even some of our actual skill training. We have a bunch of cages and a bunch of things we do with our athletes. But again, I'm not telling you this because I'm trying to impress you. I'm telling you this because I'm trying to say I'm a mutt. And my experience has really helped me with the shoulder, because more than anybody else, more than most people out there, I've worked with thousands of injured people, and I've worked with thousands of healthy people. And I'm telling you, that difference, that perspective that you learn from working on both the injured and the healthy people, make me better at both of the other directions, right? Does that make sense? Because when I went from the rehab world and started working within professional baseball with healthy guys, I thought I knew a lot of things, and I was very quickly humbled that I didn't know as much as I thought I knew. Right. So you actually kind of learn from that experience. So we've put all these things together: the clinical research that we've done in the lab, some of the research we've done in the clinic with some of our studies that we've published, these book chapters, all these things, the working with athletes, we put it all together. And I'm a mutt. And this is kind of where I'm at now in my career with working with shoulder patients. So what I love to do is share this stuff. And this is one of the things I tell everybody, again, my students, the people like in my mentorship program online. What I kind of tell them over time is like, look, don't go online and proclaim expertise or proclaim that you are like better than anybody else. Share your journey, share what you're learning and what you're doing to grow online. That's what you should be doing with your social media profiles, your website stuff. So I've been doing this for over 10 years now. I have a website with I think it had over 1,000 articles. I think, there's plenty to catch up on there. Tons of stuff on our social media accounts. We have a big podcast. We just hit 200 episodes earlier in the year that we put out there. So there's so many ways that we put our educational content out there. But again, it's about putting together all that stuff. It's about being a mutt and putting it together and sharing it with you. And that's what we do. And some of these webinars are part of that too. So one of the other things we like to do, and I'm still trying to admit some people from the waiting room, is we try to share some of the things we learn with some of our courses online as well. So I have a bunch of different online courses. I have an inner circle mentorship program where essentially you can join my mentorship. There's a ton of different educational opportunities. We have presentations just like this that we do every month. There's an online community that we talk. I have some specific courses like the one on the shoulder that is really like a really detailed, comprehensive program. Kind of have have everything, but I love sharing this stuff. Okay. So that's a little bit about me for all the people that maybe are new to me, because I know there's a lot of new faces here. I know we got a lot of people from social media that weren't necessarily following me already. So welcome. And hopefully now you understand a little bit about my perspective with what I teach, because I think it really comes back to being able to see the injured people, see the healthy people, but also do some of the clinical research ourselves. I think that just makes it a completely different perspective that I think is often very helpful. Oops, I keep drawing on the screen. I apologize. Let me see here. I'm going to try to admit a few more people. I can't do that. Sorry. Perfect. I just want to make sure everybody gets in that can get in if they want. I keep drawing on the screen. Okay, obviously we are perfect. Okay, awesome. All right. Just make sure everything's going here. Perfect. All right. So for everybody now, we're going to advance forward. I want to talk about these 5 keys. Okay, so now you know a little bit about me. The shoulder is one of those things where if you've been a physical therapist, an athletic trainer, an occupational therapist, a chiropractor, anybody, I'm sure you've seen tons of shoulder injuries in your clinics, right? And when they come in, sometimes it's confusing. Sometimes you don't know. Sometimes they just come in with vague pain. And it's one of those things that, I'm sure you've seen it. You get scripts from the physicians or whatever that come to you with just these general terms like shoulder impingement and, little things like that, anterior shoulder pain, that don't necessarily tell you enough. And that's kind of why we're going through some of these principles. I think it's going to be super helpful for you. Okay. So we know they're common. For me, it's this constant battle between mobility and stability. The shoulder is such a goofy joint that it can do some really crazy things that's really beneficial for our function, but it's this battle between mobility and stability. Once you kind of take a step back and think that that is the main thing we need to be careful of and we need to pay attention to, then I think it becomes a lot more clear what we need to do. Okay, so let's go through that a little bit. Here's a good example, right? This is pretty loose, right? That's somebody that has laxity of their shoulders. Clearly she's a cheerleader. That's like a cheerleader outfit, right? I don't even know what she's doing. If you actually pay attention to her shoulder, I think it internally and externally rotates. It goes around in circles, right? If you actually pay attention to what she's doing. She was a knee patient of mine. She wasn't a shoulder patient of mine. She actually tore her ACL, which is a whole nother conversation, right? But she came in and one of these days, she was like, oh, did I ever show you what I can do with my shoulders? And I'm like, no, right? So she shows me this little thing that she can do. And it's a great example of how mobile the shoulder joint is and how loose it is. And that's coming from somebody that's completely asymptomatic, right? But it has to be able to do all those amazing things for us to function. So you could have somebody that has shoulder pain just because they have some congenital laxity, like her, right? She has so much laxity and looseness of her joint that over time that could cause some dysfunctions. A lot of times you can see some acute things. Let's watch this guy down on the bottom left, number 0 here. Watch, he's about to dive under his left shoulder. You see that right there? He falls on his shoulder. Their other player jumps on top of them here, and you can see him, ooh, something doesn't feel right. Wait for it. Once that guy moves, you can see it. It's just sitting out. It's dislocated. You can see a big sulcus sign as he's just sitting there, right? Sorry, I know. At least it's nighttime, right? And it's not morning time. We're all ready for the gruesome videos right here. But a good example of now where you have somebody that's just super duper loose, that's all the time, and then you have somebody that has an acute traumatic injury. 5 seconds before this guy was completely asymptomatic, right? And he was pristine stability of his shoulder. He had no issue, but then boom, all of a sudden he has gross laxity of his shoulder, and it happened like that, right? So you have somebody that's been slowly loose over time. You have somebody like this now that is a little bit more traumatic of a nature. Now, you can have different types of traumatic injuries. It doesn't always have to be sports, right? Sometimes it's just some normal people too. Some even like social media influencers can hurt their shoulder sometimes too, right? You can have all sorts of different ways to injure your shoulder, right? But what's really goofy is what this allows us to do functionally, right? Because some people embrace having this laxity, and some people, it really is debilitating for what it is. But then when you get to some of these high level athletes, and I'll try to kind of push this along a little bit, I got to turn the annotation thing off. because I want to show you that a little bit more there. Watch this shoulder. This is at a 60 frame per second video, which shows you how slow-mo this video is. And that shoulder has to go through extreme range of motion of internal and external rotation. And to be able to throw that ball 103 miles per hour, this particular guy can throw it that hard. So what happens is now is we have this crazy loose joint, right? It can be just too loose in and of itself, and it can get damaged in an injury like you saw that person diving. And you can see why the battle between mobility and stability becomes super important. To be able to do amazing things with your arm like that gentleman just did right there, you have to have a certain degree of mobility or it wouldn't work, right? So most of the athletes we work with have too much mobility, and it's almost like a balance between that at all times. They're almost on the verge of having some laxity that causes instability all the time, right? So something we have to kind of pay attention to. So we know that the shoulder is the ability to do all these crazy things. What we're also seeing now in our clinics is that the general public is just more active. Everybody's doing more. Fitness is so popular right now, and it's amazing, but we're starting to do some really goofy things with their shoulders, right? Everybody wants to do Olympic lifts, which is great. I like that, right? But not everybody's ready for it, right? So, everybody's a little bit different, but we're seeing just more activity over time with our shoulders. And we're also seeing that people are staying more active later in life, and not just with basic things like golf, right? But we're still doing things like advanced fitness and other things as we get a little bit older. So to really understand the shoulder, you need to understand that the spectrum of everything we talk about is going to apply to all these different people. And it's super complicated, but what we do doesn't need to be complicated. And that's the main point of this presentation. What we're going to do is we're going to break it down to these 5 keys, right? And these are the basics. If you can truly master these, you really simplify a lot of different things. I have patients all the time that come up to me and they say like, "Hey, Mike, why does my shoulder hurt?" And I'm like, "Well, it's because you're a baseball pitcher," right? And they were looking for a different answer. They wanted to know like a thing they did. I'm like, "No, it hurts because of what you do with your shoulder, what you may do depending on what your activities are," right? So these are our 5 keys. We're going to talk about the anatomy of the shoulder, and not like the boring anatomy, right? Like you're already like, "Man, should I hang up now? This is not going to be a very cool presentation." No. And we're going to talk about the functional anatomy that matters, right? And then we're going to talk about how that matters for the mechanics of the shoulder. Because believe it or not everybody's great at the mechanics of the shoulder still. Because again, it's a complicated joint. It's a super goofy joint, right? And then once you have that, we're going to talk a little bit about differentiating the source of the pain and why sometimes that doesn't even matter, right? And that's going to be kind of like one of the main points that we're going to talk about, because then we're going to really focus on that mobility and control, right? Because remember, it's that balance that we talked about earlier. It's this constant challenge between mobility and stability. So we're going to have to be able to control that over time. So those are going to be our 5 keys. Okay. All right. You guys ready? You want to dig into some of these here? I think this is the key moment in the presentation we get in. Key number 1, understanding the anatomy of the shoulder. And trust me, this is going to be too boring, right? The anatomy of the shoulder. So we all know anatomy, right? We know there's bones, we know there's labrums, we know there's capsules, there's ligaments, there's muscles, all of that put together. But we're going to talk about some of the specifics of the shoulder and what makes this such a unique joint and how that changes what we're going to do with our evaluation and treatment, because that's why it matters, right? So let's start with a broad approach. If we just look at the back of the shoulder, so this is the back, obviously, that's your spine in the middle. That's the left shoulder from the posterior aspect. That bone right here, that's the spinous process of the scapula, right? Kind of see that right there. If you look just from this perspective, I think this is a really good way of starting looking at the anatomy of the shoulder. We're going to talk about the big muscles and the little muscles, right? And by the way, I teach the same way I talk to all my patients and clients, right? And that's an important thing for me because I kind of call it like business casual, right? Is I want to be able to be relatable, but I also want to be able to be intelligent with my conversation. But you don't want to get too deep with some of our patients, right? You want to get like those main points driven home. So when we look at the muscle groups, we talk about the big guys and the little guys. With the big guys, you can see on the external surface here, we have things like the trapezius. Look at how big that thing is, right? The deltoid, huge deltoid, which is like the big prime mover of your shoulder. Your lat, which is enormous too. Your pec on the front, which is enormous. Those are big muscles. You know what those muscles do? Those move your arm around in space, and they can move it fast and rapid, right? In all these different directions. If we go a layer deep and we start looking at some of the muscles that control the shoulder joint, now we have a completely different type of muscle. This is the rotator cuff, the scapular muscles. You can see in this photo here, this is your supraspinatus, your infraspinatus, your teres minor, some of your scapular muscles here. We took off the trap, but I would include the low trap in this area with your rhomboids, your mid trap, right? These are the muscles that help move the scapula, your levator, your serratus anterior. These are now those little control muscles. So the big guys and the little guys. The big guys move it, the little guys steer it, right? I think that's what you kind of say. They kind of work together in that manner. So a lot of times, especially with athletes, especially with people that are like fitness enthusiasts, they come to you, their shoulder hurts and they're jacked, right? They have all these big muscle groups. They're very, very big hypertrophy of their muscle groups. And then you say, well, your shoulder's weak. And they're like, my shoulder's not weak, right? They're like, they get like all bent out of shape when you say they're weak, right? But they're weak with these little control muscles. And there's a big difference between the big guys and the little guys. Okay, so this is the big thing I talk about with muscles is the big guys move the joint, the little guys control the joint. That's important because that's what we're going to focus on with our treatment techniques. Now, when we look at the stability of the shoulder, right? This is where we start getting into the static stability of the shoulder. It's the little things that keep the ball in the socket together, right? So in here, you can see we have this capsule. That's actually a decent little picture of the probably the posterior band of the inferior glenohumeral ligament. We're going to talk about that in a little bit. But you can see now we have this little capsule that surrounds the joint, right? And if you go a little deeper, obviously you have your ball in your socket, your bone, right? So you can see that you have this little teeny amount of stability from the capsule and the ligaments and these huge muscle groups that move it, right? So what do we always tell our patients when they come in? We say like, well, you know, your arm, you know, it's this big battle of mobility stability, right? And we always say it's a ball and socket joint, right? How many people have done this, right? You see how I'm using my hands? I don't know for those that can see me right there. How many have done exactly what I've done? Right? You know, I'm sure many of us have, right? I wish this is how stable the shoulder joint was, right? So I always say like, look, this is a ball and socket joint, how your shoulder moves, but it's not. It's not Pac-Man eating this little pellet, right? It's not that at all. That's not how the shoulder works. It's actually the exact opposite. And the analogy we use all the time is a golf ball on a tee. And look at how easy it is for that ball to fall off the tee. That's a really good analogy for the shoulder. That's your glenoid, that's your humeral head, right? And it's actually pretty accurate in terms of the sizing of all of it, right? So it's kind of interesting to kind of see that as you look at it from the perspective of a golf ball. So let's talk a little bit about some of the details of that. So one of the first structures that comes and helps us here is the labrum. So this is your glenoid. I tried to kind of orientate it in the same way as the T right there. So if we look at the T, this is your labrum. So we're looking at the top at your glenoid right here. And what happens is your labrum is that little cartilage tissue like your nose, your ear, right? That kind of makes the T deeper, right? It kind of increases the depth of the socket. That's one of the big major things that the labrum does. But actually does more than that. It actually has a stabilizing role, almost like the menisci to the knee a little bit, where it actually helps block some movement as well. So with the ball and socket of the humeral head, the glenoid with the labrum right here, you can see that it almost has like a buffer, almost like if you put a wedge underneath your car if you park on a hill, right? It stops that wheel from rolling a little bit. Now, all the things that it does functionally also could relate to how it gets hurt, right? So the more loose you are, the more congenitally lax you are, the more instability you may have, the more you're going to damage your potential labrum, right? And sometimes you can even traumatically kind of rip that labrum off, right? And this is like a Bankart lesion that you might have where the capsule and the labrum peel off and then you have some anterior instability, right? So you can see how that stability can, or that laxity can create some instability if you have some of those traumatic events like we saw in the videos. Now, the shoulder and the capsule are even more complicated than that. If we look at the shoulder from the side now, so it's like looking at this angle, well, it's actually this one to be accurate, right? So if we're looking at this, this is taking the humeral head off. This is the glenoid again right here. So this is the socket. And what this is like taking the capsule and just kind of cutting it down in half, right? And what you can see here is that the capsule is like this big balloon that goes around the glenohumeral joint, but it has these ligaments that are part of the capsule. Now, the ligaments in the shoulder are a lot different than other ones in the rest of the body. Your knee is a great example. Your ACL or your PCL, right? These two big ligaments on your tibia, right? You're very distinct. They have very clear roles with what they do. The ligaments within the shoulder are actually just thickenings of the capsular tissue. And you can see that's really all it is here. So we see this is the superior glenohumeral ligament, the middle, this is the inferior glenohumeral ligament. You can actually see that all it is just some broad thickenings of the capsule that kind of vary depending on where they are in which portion of the joint. Okay, so you have the capsule, you have these ligaments. They work together to keep the ball in the socket. And as you move your arm up from 0 degrees to 45 degrees to 90 degrees of abduction, you can see that they get tighter and tighter the higher we go up, right? And you actually shift from the top ligaments to the bottom ligaments that actually get stable. Now, this is super important if you're dealing with somebody that may have like adhesive capsulitis or a stiff shoulder. You can actually specifically determine the exact portion of the capsule and the exact ligament of the shoulder that is tight if you understand these mechanics. And that's a really, really important part. So we're not going to get super detailed into that stuff tonight, right? But that's the sort of thing that we can get really detailed into if we need to over time, is you can do a very specific maneuver like an anterior drawer at 45 degrees of abduction and know that I am assessing the middle glenohumeral ligament of the shoulder joint, right? But the main point for now is that we just understand that the capsule and the ligaments kind of work together and get tight as we raise the arm up overhead. Okay. Now, mechanically, what happens is what's called the hammock effect, right? And you can kind of see in this photo here, this is a person, he's internally, externally rotating his arm. And what happens is the capsule acts like a hammock, right? And as you internally and externally rotate the arm, it kind of goes to the front and to the back to stabilize your arm over time. So what I do, if you kind of look at me in the video here, I use this example a lot with my sleeve, right? This is the laxity or the redundancy that we have in the inferior aspect of our capsule. When you externally rotate, what happens is that wraps over the front and tightens up, and it gets tight in the front. Same thing when you internally rotate, it goes to the back, right? That's a great example you can show people of how the capsule wraps around and tightens into the front of the shoulder. Now, if somebody's really loose in that position, maybe they had a traumatic event where they hurt themselves, then you can determine again exactly what part of the capsule it is. Okay, so we've talked a lot about mobility. I want you to also keep in mind that when we talk about the capsule, that the capsule is also involved in hypomobility, not just hypermobility. So we talked about the redundancy of that capsule, but sometimes too, what you can do is you can take up that redundancy, and you can see it in this image here. Maybe that starts to adhere to itself, or maybe you have just some different issues with your capsular tissue. That's going to cause some tightening. This is like a beginning, early stage of like a frozen shoulder, an adhesive capsulitis. So to use that example again, what you do is you get rid of this redundancy, you tighten it up, and then all of a sudden, look, I have a tight shoulder, right? Because my capsule doesn't move. Okay, so the first key to understanding the shoulder joint is to understand this ball sitting on the socket and how loose that is, right? How it wants to fall off. So the labrum's there to get it a little deeper, and then the capsule engulfs it so that way it goes all the way around and can get tight as the person moves their arm in space. That's super important. That is what's called your static stability. Okay, there's two ways that your ball and socket stay together. One's your static stability, the other is your dynamic stability. Your static stability is this, right? It's your bony anatomy, it's the capsule, it's the labrum, it's the ligaments, right? Now, when somebody comes and sees you and they have a damaged shoulder, so maybe they have a labral tear, maybe they have a capsular tear, right? Right there, what you already know, the first thing that should pop in your head is that this person does not have good static stability, right? Maybe you have somebody that is the congenitally lax person, like that cheerleader, or maybe that baseball player that gets so much laxity into layback with his arm. You know, with that person, they have poor static stability, right? That is the number one thing you have to understand if we're going to talk about what to do with the shoulder over time: static and dynamic stability. So guess what? If they have poor static stability, what do they need to have really, really good? Dynamic stability, right? And that's the whole other process of what we do with the shoulder. And that's the big point here, is that a lot of people have poor static stability. What's the solution for it? It's to have even better dynamic stability. So we kind of said all the time, it has to be like 50-50. Oh, you have poor static stability, you need better than average dynamic stability. I have worked with people with gigantic labral tears, huge labral tears, that can still pitch in Major League Baseball and not have any issues. I've worked with people in their 60s and 70s with full thickness cuff tears that can raise their arm up over their head. How do they do that? It's because they have good dynamic stability. Okay. So that's that big first key right there, is understand the anatomy and how that plays together. Now, what comes after the anatomy is the mechanics. So if we talk about the biomechanics of the shoulder, and we talk about how that's relevant to what we're going to do with our evaluation and treatment. Okay. Makes sense. So we talked about this, right? I hate to say it. I'm going to be the first to tell you this. This is a terrible example. And I know I'm the one that just gave you this example. So I'm making fun of myself. That was a bad example. Your shoulder is not a golf ball on a tee, right? You know what it really is? It's like a ball on a seal's nose. That's the difference, right? So it's similar, right? But you know what the difference is? That seal moves. And that's the crazy part. So that seal is your scapula, and that ball is your humeral head. Notice even with what the seal's doing here, he's balancing that. Notice how the basketball's not moving. Look at the lines on the basketball, right? You see that? That is staying stable, right? That is dynamic stability, right? Your scapula is moving around, but the humeral head is staying within the socket. That is appropriate dynamic stability, right? So I wish it was as easy as a golf ball on a tee, but it's actually more of a seal with a ball on its nose, right? Because that has to move around. So it's one thing to be able to be stable, static in place, but to be able to be stable throughout the range of motion is very, very challenging. And that's really our goal with our rehab, is to be able to do that. So we have to get the seal and the ball to be nice and stable. Okay. I thought that was a great video for it. When you move the arm, and this is just an example, it's a combination of both your scapula and your humerus. Everybody kind of like forgets that, right? But if your arm goes up overhead a total of 180 degrees, well, 120 of that or so is from your humerus, and the other 60 is from your scapula upwardly rotating. So you have to understand that concept too, because sometimes you can have an issue with your scapula and not even realize it. And that's what's causing most of your shoulder problems, right? So you have to be able to move those two together. Okay. So it's like a seal with the ball on top. Right? Now, what's the seal do? This is the important part. It's the scapula thoracic joint. That's another thing we always forget. The scapula sits on the thorax and it moves over the thorax like this, right? By the way, if you search for GIFs of seals, tons of great ones. I'm just going to throw that out at you. Find good, funny videos like this. But this is what the scapula does over the thorax. So the sand's the thorax and the seal is the scapula, right? It glides over the thorax. So the seal is only going to be where it is because of where it sits on the thorax. So if you have terrible posture, if you have big kyphosis in your thoracic spine, you're somebody that sits all day, then your scapula is starting from a disadvantageous position, right? Now, I'm not saying posture does anything, right? Posture doesn't cause your issues or anything like that. But what it does is it pre-positions your scapula in a certain way. Right. And we do know that things change, right? Here's just like a dynamic MRI between a good posture and a bad posture. But this is somebody with a posterior scapular tilt and somebody with an anterior scapular tilt. And you can see a large difference in the subacromial space. This happens every time we use our arm, right? So the example we tend to do, everybody can do this at home too, everybody's kind of sitting, is lift your arm up overhead. You get some pretty good motion, right? Yeah, do it. Let me see it. Right? Lift that arm up overhead, right? Slouch terribly, which most of us already are, right? But slouch terribly, try to lift your arm up. It doesn't go as high, right? That is just showing you the relationship between how the scapula and the humerus play together. So again, we have to have the muscles that steer the scapula to help stabilize. That's an important thing, okay? So we have the rotator cuff, we have the scapular muscles. Remember, it's the battle between big guys and little guys. The big guys, like your pec, your lat, your trap, your deltoid, and your cuff and your scap muscles, right? They all mechanically work together. That's an important part. So again, when you look at the big guys versus the little guys, this is a great example here of our net forces. The deltoid moves the arm up in space. It lifts your arm up. That's what the deltoid does. The rotator cuff helps stabilize and keep the ball in the socket. So that happens with the supraspinatus superiorly, but also your infra and your subscap, that's on your anterior and posterior aspect of the shoulder. The rotator cuff works together to blend in with the capsule to create that dynamic stability. So your big guys move it, your little guys steer it, okay? Another example, and I think this is a great one here. These are the resultant force vectors of the deltoid and the rotator cuff working by themselves, okay? So what happens is as your arm elevates and goes higher and higher up, what happens is you can see that the deltoid at the beginning of your range of motion has a superior force vector. And that makes sense, right? Think of your deltoid, right? It comes up and around and attaches down here. So at 0 degrees, if it contracts, where's the force vector? It's superior, right? Does that make sense? As you get up higher in space, now look at my deltoid. It's from here to here. If that contracts, what's it do? It brings the joint together again. So down here, it lifts it up, and up here, it helps compress, right? So you have that deltoid change its role as it goes higher up. When we get to some of our manual techniques, and I'll show a video of this later, we use that to our advantage, right? Because we want somebody that has a poor rotator cuff to still be able to stabilize. Sometimes the deltoid can help us. Sometimes it creates a shoulder shrug sign, and that's bad, right? Sometimes if we get it up here, we can stabilize. How many people have seen somebody with a shoulder shrug sign, maybe because they have a rotator cuff tear, not because they're tight, that's a different version, right? They have a rotator cuff tear, they have this shrug sign, but if you passively bring them up to about 100 degrees and let go, they can lift their arm up all the way. That is why. This is the exact mechanism why that happens, okay? Does that make sense? So the deltoid has this superior force vector, but throughout the entire range of motion, the rotator cuff keeps the ball centered in the joint. And that's how they work together. The big guy moves you, the little guy keeps the ball in the socket. Super important, okay? Now, we can see that in two ways, right? So a great example here, the shoulder shrug sign, like I was just demonstrating here. Sometimes you see this. This is somebody, she can't even get it past, that's probably about 60, 70 degrees if she takes away her cheat, right? And that's all she has. She has a big rotator cuff tear. But sometimes we see this as well, right? Does that look like good elevation to most people? No, it's terrible, right? He's just side bending. If you actually look at his shoulder, he thinks he's fine. He thinks he can raise his arm up all the way overhead. He's only raising that about 105, right, degrees of elevation or so. That is somebody that is having an issue with the stabilizing muscles, the rotator cuff versus the big muscles. And what can happen over time is we can get this superior humeral head migration, which just causes a lot of problems, okay? So when we talk about the mechanics, that is now the difference. And what we're doing with the mechanics is that is the dynamic stability, right? So the static stability is the joint. The dynamic stability is how those all play together. Okay. Now, once you know those two keys, we can start talking about what that means to the shoulder joint and what some of the different things that we see with some of our pain patterns are, right? Because you have to understand this battle between mobility and stability. But then we get somebody with shoulder pain, right? That's probably the number one thing you see, right? Is just shoulder pain. I don't even know what that means, right? Somebody actually comes to you with shoulder pain. What do you do, right? Well, most of the time they have anterior shoulder pain too. You see that, right? So what do we say? Oh, it's his bicep, right? We say that all the time, like, oh, her bicep hurts. It must be her biceps, right? Well, I always try to kind of make this point here that if you really look at the anterior aspect of the shoulder, right? We have our supraspinatus, we have our subscap, we have our pec, our lat, everything. They all come and attach all right here by the biceps, right along that bicipital groove. So when you have anterior shoulder pain, I've seen all of these cause issues or be the thing that's causing issue. But here's the good thing. It doesn't matter. It doesn't really matter because it's not going to change the principles that we're going to talk about. Shoulder pain is shoulder pain. Doesn't really matter what structure it is. Is it their supraspinatus? Is it their bursa, right? Is it even maybe their labrum that's causing them pain? It doesn't change my treatment plan. And that's the whole point of this presentation, okay? So when we get to this third key here is understanding the differentiation of all these things, we do need to perform a clinical exam, right? And you do need to know your special test so that way we can rule out big things, bad things. We want to diagnose the big ones like a labral tear, right? Or a rotator cuff tear, something like that, right? But those are the easy ones. Those aren't the ones that stump you, right? They come in, you come in, they have a positive drop arm, they have a positive lag sign. Okay, yeah, they have a rotator cuff tear. You know what to do. They come in, maybe they have like a big apprehension, positive like apprehension relocation sign or something like that. You know they have anterior instability. You know their problem. This is for everybody else. The person that just comes in with shoulder pain, which is probably the vast majority of people that we see, right? It's probably 80% of the people, right? So you have to do your exam to rule out the bad things. But for me, it's less about the symptoms and it's more about the findings. So we say this all the time when we teach again with our students and the people in my programs is you want to do two things when we're evaluating the shoulder, right? One, you want to do a structural exam, and two, you want to do a functional exam. And you want to put those two together. Structural is how's the labrum look, how's the capsule look, how's the rotator cuff look, those sorts of things, right? So those are your special tests. Functional is how well do they move? Can they move their arm up over? Can they push? Can they pull? Right? Can they do these motions with that? And then we put it together. And then what we do is we create a big checklist of suboptimal things. So we might end up finding that they have anterior shoulder pain, but what they have is poor thoracic extension, maybe weakness of their external rotators, maybe weakness of their low trap, right? And maybe some tightness of their subscap, right? I've just made all that up, right? What we're going to do there is not necessarily treat the shoulder pain. We're going to work on that suboptimal checklist. We're going to work on those four things we kind of just talked about. And that's the important part. Okay, but I'm going to make it easy again and kind of talk it through a little bit here with the basics. Here's what I want you to think of first. Are they too loose or are they too tight? Right? And it goes back to everything we said at the beginning. It's this balance between mobility and stability. Are they too loose or are they too tight? Those are the first question you want to ask with anybody with shoulder pain. Okay, so you can do your tests. You can do like anterior drawers, fulcrums, posterior stuff. You do all that to see how loose they are. You can do a sulca sign. You can do a load and shift to see how lax they are. You can do all those things and also look at their tightness to see how tight they are, right? That's the first thing you got to look at in your shoulder evaluation. Are they too loose? Or are they too tight? The third thing then is, can they stabilize? And we do that through first by just doing our manual muscle test. Maybe we measure it like I'm using a handheld dynamometer here, whatever you might want to do. But are they strong enough to stabilize? I don't care about their pec, their deltoid, their lat, their trap, right? All those big guys. I don't care how big they are, how hypertrophied they are. I want to know how the external rotators work, the internal rotators work. Full can, for example. I want to look at those little stabilizing muscles, okay? Because we want to see how those all work together. Now, you can go deeper, right? And you should. I tend to break down my shoulder exam into two things, local and global, right? Locally, I want to look at the shoulder joint. And then globally, I want to look at how that all attaches. So the scapula, the thorax. And then even if you get into the thorax, you could argue the whole lumbopelvic area, right? Because you just tilt your pelvis, that changes everything. Let's play another game, right? You guys are all getting comfortable on the couches now. It's a good thing about Zoom. We're all on couches and stuff, right? So we slouched, we raised our arm. I don't want you to slouch now. What I want you to do, I want you to pelvic tilt anterior and posterior. That's it. I don't even care. Some of you are really slouching. I can see in the video, right? Those are tough, but anterior tilt, posterior tilt, anterior tilt, posterior tilt. When you get into this nice anteriorly tilted position, look at what happens to your shoulders, right? You kind of sit upright, right? So everybody always says, what's the key to good posture and sitting for your shoulder? I always say scoot to the front of your chair. Right? And I'm going to do that right now in my chair. I'm scooting to the front of the chair and that gets my pelvis a little bit more neutral. And look, I just sat up, right? When we sit back, we posterior tilt and then it gets worse, right? That's how the lumbopelvic affects the thorax, which affects the scapula, which affects the glenohumeral joint. And that's how that all kind of goes together. That makes sense? So that's the third key, is understanding that, yes, you need to perform your clinical exam and you have to know your special tests and you have to be able to differentiate from the really bad things. But more importantly, it's just understanding, are they too loose? Are they too tight? And can they stabilize? 3 questions. That's it. See how we make the complicated simple? Just ask those 3 questions and that's pretty good. So the fourth key now, we have to now restore mobility. If somebody has a mobility restriction, you cannot pass go. You cannot collect $200. There's nothing to do until you get that mobility restriction going, right? I actually don't even do a ton of stuff for strengthening and control type drills if somebody has a big mobility restriction, because oftentimes that's just going to change the osteokinematics of the joint and oftentimes just make them irritable, right? So if their capsule's tight, and I'm just going to use this Pac-Man example again, right? And you're more congruent, and then we just do exercises, Sometimes that grinds a little bit. Sometimes that causes a little bit more inflammation, and that's worse. So the first thing we do they have a mobility restriction? I would say I'm a little bit different with my patient population. I'm definitely more athletic. Don't get me wrong. I've done everything in my career. Definitely more athletic. I'd say 80, 90% of my people have hypermobility. Hyper, not hypo, right? And I actually think in the general orthopedic population that most of you guys are probably in too, that it's probably pretty similar, right? Believe it or not, there's more hyper than hypo with the shoulder, okay? Now, here's one big key though, and I think this is the most important part of mobility for me. And this is where I think I'm different than a lot of ways that some of the schools teach it. If you have loss of mobility, this is the first thing you have to work on. But I always work soft tissue first. Okay, soft tissue first, capsular second. How many people learned it the other way around, where it's joint first and capsule first, right? That's like a tried true, like old school, like joint type notion, right? And that was taught that way for a lot of different people. And I respect that. That's probably accurate with some joints. For the shoulder though, I don't do it that way. Remember, I do think there's a lot of hypermobility in most of these people. And when we have some restrictions in mobility, oftentimes it's not global, it's just in like one particular area. But we always start soft tissue first. Now, what do I mean by that? The muscles, right? And oftentimes that's from overuse from the activity they're doing. You want to get mobility from your soft tissue techniques, like I'm doing in this image right here, before I just start torquing a joint, before I start doing a capsular mode, right? That's why you see people that everybody's trying to do these self mobility drills that are on the internet now. And that's great. I think you should do that, right? But what happens? They come to you, right? Their shoulder's limited. This is their motion, right? So what do? They go on Instagram, they find a couple of drills and they start jamming it up, right? Well, this is the drill. I'm going to jam it up. Like, well, that sounds terrible, right? Like you were tight. Jamming it into more elevation isn't going to solve the problem. That's just going to cause irritation, and that's going to cause some issues with the joint. So we got to keep that in mind. Okay, that's an important part. We start soft tissue first, right? We don't do joint mobs. We don't torque the joint into some stretches behind the back type things until we make sure the soft tissue is addressed first. Okay, and the majority of people that actually helps. Okay, then we do the capsule. Now, you can do this any way you want, right? I love using my hands. I use things like cups. I use instrument-assisted tools, anything you want. And remember, I'm a big fan. I use this analogy in a lot of my programs too, is that, look, I'm going to help you with the recipe, but you can mix out the ingredients all you want. Like, so if you don't like the cup or you don't like the instrument-assist, do whatever you want. I don't care. You do your soft tissue technique, but this is when you do it. This is the part that you want to do it. Does that make sense? Okay, so we have to address that first. Soft tissue, soft tissue, soft tissue. Then we get to the capsule, right? So how do we differentiate that? Well, oftentimes, let's say overhead elevation. So we have them going, we'll say they're supine, they're on the table, elevation overhead, and they don't have full elevation. A lot of people would start doing a joint mode. They'd start getting right in and do it like an inferior joint mode, right? What I'm gonna do is I'm gonna work on the soft tissue structures. I'm going to work on the lat. I'm going to work on the teres major. I'm going to work on the subscap. I'm going to see if I can loosen those up. And then you know what I do? I recheck their motion. That's it, right? And oftentimes they go from here to here, they get all their motion. And I say, I'm done. I don't just do joint moves because that was what I was taught, right? That's the next thing in the sequence. I got their motion back. I achieved my goal, right? Sometimes I'll get 80, 90% of the motion back and not all of it. And then maybe we have to do a little joint move, maybe something else we have to do to kind of neuromodulate some tone elsewhere. But that's a, depends on the person, okay? But really, really important for me. That's one of those tricks of the shoulder. Trust me, soft tissue first, okay? So we got to restore mobility. Okay. That's the fourth key. All right. The fifth key, this is a big one, right? Because remember, we promised 5 keys, is we have to restore control. Again, it's a balance between mobility and stability. If they're tight, that's our number one thing. Most people aren't tight. You can skip the 4th key and go right to the 5th key. That's where we work on control. Now, here's the trick with the shoulder that I think a lot of people run into problems with here too, is that they skip some of the basics. And look, as a profession, I think we did this accidentally because we got into the functional training mode and to get really like cool with our exercises. And I think that is fantastic. I'm one of the people that do that and teach that here. But I think sometimes, especially if you're a student, you're a new grad, you're still getting kind of used to like your repetitions with shoulder patients. You see some of the things we post online and you think that that's like all we do. when realistically we're doing stuff like this, side lying external rotation. We're laying that foundation, we're baking the cake before we get to all the frosting. That's a big important thing for me. Okay. So the number one thing we need to do control, and I always say this is a phrase I use all the time: a weak muscle can't stabilize. Right. So if we're trying to stabilize, the whole key to the shoulder is dynamic stability. Right. If we're trying to do that, we have to have good strength. So when we talk about control, that is isolated strengthening of a specific weak muscle. So maybe that's external rotation. Maybe that's the lower trap, right? They're not getting a good posterior tilt or an upward rotation of their scap, right? But when something is weak, we can't just go to a functional movement because they're going to compensate. It's not going to go well. That's a poor movement skill. We have to do it in a controlled fashion. So the first thing we do is we do isolated strengthening of a weak muscle. So let's say external rotation. Then we'll start doing some of our manual techniques. We'll do things like manual resistance. We'll do rhythmic stabilizations, which is kind of what I'm doing in this position here in this video, right? Then we'll start to incorporate some of the kinetic chain. Remember, we do local and global, right? So I'm just showing a progression for external rotation here, but you can see now he's in a side plank position. Why? Well, now he has to lock out his left thorax. So for the right scapula to move, you often need stability of the left thorax. So your left obliques need to engage to hold that down. So that way now my thorax is in place and my scapula can move. Okay, that's how we put those two together. Then we get them in these functional positions like half kneeling. Maybe we're using a different technique here. We're doing a perturbation with some rhythmic stabilization. That's the fancy stuff. Too many people jump right to this exercise and they haven't gotten the isolated strengthening of the weak muscles yet. So in order to control, you have to have isolated strength and then work on the dynamic stability. Okay. And remember, we kind of showed it there: local and global. Local of the rotator cuff, global of stabilizing the lumbopelvic and the thorax while the arm moves. Okay. So look, there's tons of different ways we do this, right? So I want to show you just like a couple of videos here. We'll go through a few of these. I'll be the first to tell you there's a million ways to do these manuals and that you can make up your own ones, right? What I'm going to do here first is just the basics of shoulder stability. I'm going to do rhythmic stabilizations. Now, what I'm doing is I'm putting her arm in this right position. Remember what we said earlier, that the deltoid at about 90 to 100 degrees is now helping the rotator cuff because of the force back there. So we're going to start our rhythmic stabilizations right here, and I'm training her to stabilize against these rhythmic isometric contractions. I'm saying to her, don't let me move you. That's an important concept. Don't let me move you. You have to stabilize that arm in space. This is like step one, super basic. You can't move past this until you can stabilize that arm pretty steady. Okay. So that's just rhythmic stabilizations, alternating isometric contractions. As she gets better, we're going to do them at different ranges of motion. I'm going to go up overhead. You can see that's a little bit more dynamic. As she really gets better, we're going to go lower. Lower is harder. Why is it harder? Because now the deltoid wants to go superior, right? We kind of talked about that with the mechanics. We see how those go together. But it's about kind of performing those basic rhythmic isolated rhythmic stabilizations. Now, again, just showing you some more examples here. Now, why we do this left oblique type position. We're going to get her in the side plank position. She's just on her knees, so it's not an aggressive side plank. And she's going to come up into this position. And now I can do a bunch of exercises. I can do side lying external rotation. I can do a row maneuver. Here, I'm going to do like a full can. So I want to get some supraspinatus strengthening right here. And I'm just doing some resistance in this pattern while she stabilizes her lumbopelvic area. I can do some rhythmic stabilizations. We can put that all together. But again, an example of how we put it together. Sometimes we do some external stimulus too, like here's a ball. We're going to do some dribbles against the wall. So now she has to have this force, a little bit of a perturbation with the ball. And then every now and then, I just like to annoy my patient. So I'm going to give her a big perturbation and we're going to rhythmic stabilize. So that way she has to hold that in space. And you can see, look at her muscle groups, right? Now she's a gymnast, so she's got a ton of muscle mass, but look at her, how her scapula has to stabilize. Those muscles are on fire while we're trying to prevent her scapula and her shoulder from moving in that position. Okay. So remember, we can't do any of these drills if she's weak, if she doesn't have her external rotation strength, if her scapular muscles aren't steady, right? So we have to be careful with that. We don't want to jump to these advanced exercises. That's a big mistake I see people get into. They jump right into these advanced drills when they have isolated weakness. You have to earn the right to be able to do these drills. Okay. So, and that's kind of the point of this presentation. Some of the things I want to get across, some of these keys right here. If you have a mobility restriction, that's your number one focus, right? If you do have a mobility restriction, it's soft tissue before capsule, right? If you have somebody that has a weakness or a control type issue, you have to get that isolated strengthening first. Those are super important, right? We've gone away where people are saying stuff like sidelining external rotation and tubing is too basic and too boring. And that is for somebody that's healthy, but for somebody that doesn't have good control of the shoulder joint, that is the most important thing that they could possibly do. Does that make sense? You have to really focus on that. Okay. So those are my 5 keys. Right now, we could get super deep into each one of those, right? And I think that's kind of the big key. But if you understand that right now, take a step back and think about the last 5 people that you've seen in your clinic, your training room, wherever you've been, right? Think about the last 5 people you've seen with shoulder pain. And if you just follow those principles, you see how those can probably get the majority of people better. And it doesn't even matter what the diagnosis is. It doesn't matter what the structure is. So you're working on those basic principles because you understand the anatomy and the mechanics of the joint, and that you understand that the majority of time that their pain is secondary to that mobility and control balance. Maybe they have impingement, maybe they have a labral issue, maybe something's happening in there because they can't stabilize, because maybe their static stabilizers are too tight, right? Even though that's the rare one, or they're too loose and they don't have good dynamic stability. That is the number one reason. So you focus on those things, you are going to make the most impact on people just by following those basics. That makes sense? So that is, to me, the overview, but probably the most impactful thing you can think of in your head, right? Now, I know that wasn't like super deep. It's kind of more detailed. For those that want to go deeper, I have a full deep shoulder course. And this is a really huge online program that I've been doing now for almost 10 years. It has everything I do for the shoulder joint, my exact evaluation and treatment thing, everything we do. I go over my full exam from like start to finish with the evaluation. So I team up with Kevin Wilk for some of these videos. There's some really good things. We talk about all the treatments I do, all the manual techniques, everything that you do. Is videos of everything. But then more importantly, we go through all the specific injuries. And that's something you can't really do in a webinar like this. Is I want to talk about exactly what to do with impingement. I want to talk about what you do after a rotator cuff repair. How does like a small rotator cuff tear vary from a very large rotator cuff tear, from example, right? Those are some of the things that you can dig into, right? So we do that. We talk about instability, talk about traumatic, atraumatic, post-operative, slap tears, adhesive capsulitis, osteoarthritis. It's a big detailed course. So you get everything, you get all my videos. There's a community that goes with it, a bunch of journal article readings. Big thing is there's also CEUs for it. And look at how big that is. 24 CEUs for PTs, almost 20 for athletic trainers. We're in the process of applying for the occupational therapist as well. So if you actually sign up for the course, we'll probably have this approved, right? Yeah, you got it. I know a lot of people are excited. They're coming. The AOTA just like revised their whole process. So we had to kind of do things over again. So that's coming, but if you sign up, you'll eventually get that because it'll be sitting there. You can just take the test when it's ready. But we have this whole big program. And part of the reason why I wanted to do this big webinar is that this is a big week for us. We do this every now and then. It's usually about once a year or so, but we offer it for a huge sale of 50% off this week. So I'm not big. I'm not like a big sales guy or anything. I'm the educator type guy. But for those that want to dig deep into this shoulder stuff, you can get this program. There's a link right here. We're going to send out the recording and we're going to give you the link. I'll send some emails this week, but it's this week now through Sunday. You can save half off the program. It's usually $500, but with this program, it's only $250. And that's pretty huge for 24 hours of content. So anyway, not my thing. I hate this part, but for those that want to get super, super detailed, trust me, this course is super detailed. This is amazing. But more importantly, I want to spend the rest of our time together here going over some of your questions. Okay. So let's do this now. I am going to stop sharing my screen. If you have a question, I want you to type it into the chat box. Okay. And I'm going to open that up and try to go through it as many as we can. Okay. I'm going to do my best, but type away and I will start going through them. Okay. Everybody ready for that? Let me see here. Let's see. All right. Oh, we got a bunch of chats. You guys are good. You guys are awesome. Let me see here. Awesome. Okay. All right. let's see. Woof, you guys were good. All right, perfect. Let's see. Yes, we're gonna so if people ask about the recordings, we're gonna send out some of the recordings. Yeah. There's some funny comments in here. See, I should have been paying attention to the comments. This was more fun than my presentation. Let me see. There's got to be some questions coming here. Okay, good, perfect. All right, first question that I see, and trust me, don't be shy. If you have a question, throw it in here because I love seeing all these nice faces in here. I'm gonna kind of scroll through as I go through them. First question is from Tyler. He says, "What kind of soft tissue mobilization techniques do I like to use and find the most helpful?" So I kind of alluded to it in the presentation. I use my hands, I use cupping, and I use instrument assisted tools. With my hands, I do deep tissue and I do almost like a pin and stretch, like quite a bit. Now, for me, I intentionally do all those. And that's actually, we talk about that in my big champion performance specialist course, like kind of that whole recipe that we do that for. I really think that, look, you guys know, it's not about adhesions. We're not breaking up adhesions. We're not like doing anything crazy with that. We're probably neuromodulating tone a little bit. If you go through all the fibers that could cause some tone and cause some issues in your body, I want to try to stimulate as many of those as I can with my techniques. So here's a great example. Let's talk about cups versus instrument assisted tools. With a tool, I'm giving a little bit of like a compression, but I'm also almost kind of doing a shear with the tool. The cup is a traction. Those are two different nerve fibers that do traction and shear and depth, right? And all those different things. And the new one too now that everybody's doing a little bit more is the vibration gun. So like the vibration technology. And again, those are different nerve fibers. So for me, I want to stimulate all the nerve fibers as I can. So we do a combination. You kind of saw it in the picture. I'll put one of those cups. I don't do the ones where you pump up because I want to be able to move it around, right? I don't want to just sit there, but I'll throw one of those silicone cups on there. I'll do some instrument assisted away. I'll move the cup back and forth. I'll put it back and we'll kind of keep doing that from wherever that position is. Then I do a lot of like pin and stretch, or a lot where I kind of like pin the muscle and move it through there. Okay. So I talk about all that in all my other programs, but some good ones there. But good question though, Tyler. Let's see. David says open versus closed chain. So I love questions like this. It's like peanut butter or chocolate. And I'm like, I don't know. I mean, I'm gonna got them right here, right? It's the wrong side, right? Perfect. So I don't tell my kids I steal their Halloween candy. So we hide them in daddy's office, right? Because, I don't want them to get all the sugar, right? So I'm trying to help them here, but it's chocolate and peanut butter. So the question is not open versus closed chain. It's just do both, right? Open chain and closed chains is very good. For the shoulder, closed chain is helpful because it creates some stability of the joint. Okay, so we use that. It's a tool that we use if that helps. I like it. All right, let's see. Next one. Do you think mobility issues are more due to problems with stabilization? Not if you're tight, but let me keep reading. So would working on stability for a less than mobile shoulder be a good idea to help improve range? I honestly, in my humble opinion, with the people I've seen, if you have a mobility restriction, it's not because you're too loose. It's you have a mobility restriction. I think the majority of time for me, it's soft tissue, sometimes capsular. When it's capsular, it's usually obvious, like they had a surgery, right? Or they had like a big injury, or you have like a raging adhesive capsulitis, like somebody actually has like a real adhesive capsulitis, like an inflammatory process in there. That makes sense. Taylor says, "What's my favorite special test?" It's like asking which of my kids I like the most. I don't know. It depends on what's wrong with them, right? So there's a bunch of good ones. In the course, we go through all of them. When this is funny. We talk about this with our students. It's about the difference between like an expert clinician and a young like new grad type clinician. It's often that our treatment algorithm, our exam algorithm in our head goes a little faster. So I don't do every special test on every person. It's when I do one, it usually then leads me down a path, right? And that's kind of how you navigate. Okay, so we go over that in the course, but the special test has to do with what you're doing. Let's see. Matt says, when would you consider someone to be strong enough to advance the neuromuscular stabilization drills? That's actually a really good question. I do some of the basic neuromuscular and dynamic stabilization drills right away. Right. So like those basic rhythmic stabilizations, for example, we just don't get too crazy, like down that spectrum of the functional stuff until they're ready for it. Everybody always asks that post-operatively too. When can you start rhythmic stabilizations post-operatively? Remember, what's a rhythmic stave? It's an alternating isometric contraction, right? It's isometric contraction. So usually I'll start rhythmic staves just a few days after isometrics, right? So we're doing that at the very beginning of an injury, right? That happens pretty quick. Now we might be really slow and deliberate with it, right? I'm not like doing, my crazy movements with them, but you can start that and you can adjust and you can go over all that. Makes sense. So let's see here. Perfect. How much do we push through pain when first starting with a patient versus maintaining pain-free activities? That's actually a good question. It depends on the pathology, right? I would say in terms of like pushing through pain, a lot of times with the shoulder, in my experience, if you're having pain, especially like specific shoulder pain, pushing through it keeps you inflamed. And that inflammation then inhibits the rotator cuff from working. And then your rotator cuff isn't there to stabilize. And you're seeing this downward spiral. So as you all know, when you have pain, you have inflammation, it shuts down the muscles, the stabilizers. I think, and this is what I kind of tell everybody, that's like our old process in our head. That's like telling us to go sit in the cave and don't go hunt today. Right. So you're just like, you're hurt. I'm gonna make sure the muscles don't work. So that way you just sit tight today and don't do anything. But what do? We go hunt, right? Because we're idiots. We're stupid humans now. We go and we do as much as we can, right? So we don't want to do as little as we can. We want to find that like maximum dose and try to like get there every time. So that's what we end up doing. So oftentimes with the shoulder, like if you have specific like anterior shoulder pain, if we're trying to work through that a little bit, oftentimes that keeps the cuff weak. So you might see somebody that has some weakness of the rotator cuff, and then you start working on them, and in like 2-3 weeks, their strength jumps up. That's not necessarily weakness. That was a inhibition, right? That was because they were inflamed. Maybe their rotator cuff was inflamed. So now all of a sudden, like you get rid of that inflammation, you settle them down, you get their mobility back, you give them like a little room to breathe, and then all of a sudden their strength just jumps right back up. That's the cool thing to do. So I would say most of the time in the shoulder, I don't work through a lot of pain. Right now, if you were talking about like patellar tendonitis, right, or like lateral epicondylitis, that might be a completely different answer for me. But for the shoulder, I would say be careful with that. And this, by the way, is another great example where if you just see like one social media post, like on Instagram, on how like working through pain is helpful, yeah, it's helpful for some people and it's really bad for other people, right? You got to keep that in mind with context. That makes sense. So let me see. Gabrielle asks, how do you address lack of scapular upward rotation? It would depend on why they have a lack of scapular upward rotation. Sometimes it's a mobility concern, right? I love saying all these like big ifs right here. Sometimes it's like a mobility thing. Maybe they're like upper traps all jacked up or something like that. I mean, I'm not sure. Sometimes it's a nerve thing, right? So sometimes you actually have like a real issue, like maybe like a long thoracic nerve injury. That's a big deal. That's going to be a different treatment. And sometimes it's just weakness. A lot of times, especially with you see the people with us with shoulder pain, they have super hyperactive upper traps and then really weak low traps and serratus, right? So what we do is we try to get the low trap and serratus to be stronger. We try to get them away from like if they're especially like if they're going to like the gym and doing a lot, especially if they're in CrossFit. And not that it's a CrossFit thing, but CrossFit's just so pull based. It's pull, right? It's clean snatches, jerks, everything is pull. So we get away from that upper trap pull so that way we can get a little bit more lower trap dominant. Okay, that's a big one that we see. So I know I'm going like super fast, but I kind of figured you guys would rather me do a bunch, right? Like go fast and do a bunch, and you can just ignore me if I say something stupid. But I say lots of stupid things. But let me see. How much internal external rotation do you recommend for a baseball pitcher? It really depends. I mean, the more external rotation you have, the harder you throw, and then the more injuries you have. So it's a great example, right? So let's see. Rochelle says, how does the shoulder course compare to the champion performance course? Completely different. So for those that have taken my champion performance course, that's our whole system. That's our like big epic program on how we build programs to restore, enhance, optimize performance. That's big. The shoulder one is the perfect complement to that, where it's now, this is the structural stuff for the shoulder, the exam of the shoulder, the treatment of the shoulder. It's very specific to the shoulder. Let's see. Dave wants to know about a CU. Yeah, so we're not doing CUs for the free one. Obviously, we do for the big course, but not for the free one. Let's see. Minnie says you want CUs too. Yeah, no, you're good. Yeah. So, and thank you. She said she loves the podcast. Thanks so much. Yeah. So for people that take the course, when you pass the test, you get your CUs. So if you don't need them right away, that's okay. I see. Kayla says, what do you do with a patient that's unable to maintain the progress made after soft tissue appointment to appointment? That's a good example. So the majority of time, my techniques to restore mobility work, and they stick the majority of time. When they don't stick sometimes, and I'm not saying like a raging adhesive capsulitis or somebody post-op, that's a little bit different. I'm talking about just like the shoulder pain person. When they don't stick, it's usually because their activities are getting them tight again. So let's say again, you're working out, you're doing a lot of exercises, or you're playing a sport like baseball or something like that. When you use your arm, you get tight from it, and the majority of time it just keeps getting tight a little bit. So sometimes if you feel like you're not making the progress, it's because they're doing too much of other activities that are kind of getting in the way. Let me see. Ian asks, specifically about the course. If you buy the course now, do you have to take it right away, or can you delay it? You can delay it for months. So with the course, we run the shoulder course just like a live seminar. It's a 12-week period where you have to go through it. And you're supposed to do it in the 12 weeks, but like seriously, it's for you guys, or maybe our focus is you guys. If the 12 weeks goes by and you need an extension and you need to start it up, of course you can. That's not a big deal. Don't worry about that. Rochelle asks, how many exercises do you give per treatment? Again, it depends. I love those answers of depends. It depends on what they need, but I will say I do a lot of exercises and I do a lot of manual exercises with people. So people mostly come in with me. If you were with me for like, let's say a half hour, majority of the time we'll probably spend like 10 minutes working on your mobility. So soft tissue, my hands on you, getting your mobility back. Then we'll do about 10 minutes of manual exercises like the external rotation, the stave, stuff like that. And then probably 10 minutes of exercises on your own. That's if you're doing that quick 30-minute kind of session just to help. And then obviously if we have more time, we do more. So let me see what's next here. Chris asks about the example of the contralateral oblique stabilizing the torso. Would the ipsilateral obliques also stabilize? Yeah. So with core stability, and this is a big like core stability component for me. When you stabilize the core, it shouldn't just be one muscle group, right? So the big one in the day was we used to crunch, right? Or we used to say transverse abdominis. We used to really say like we wanted to get your core to stabilize. And what would happen is we would crunch and your obliques, posterior, everything would be kind of loose and you would stabilize anteriorly. And I think that wasn't perfect, right? We could do a better job than that. So what we do now is we brace, right? And when you brace, it's getting all of your obliques to work together, right? It's really hard to contract one oblique and not the other oblique when you stabilize. So yes, you want to stabilize all of your obliques. Our focus is on the contralateral one in that sling, by just saying like, give me that left oblique to stabilize, and then you brace, the whole thing does. But what you've done is you've created your pivot point as that contralateral oblique. If that makes sense. Let me see. Have you treated bilateral adhesive capsulitis? That stinks. Onset within 3 weeks of one another. That's a bad month for that person, huh? So bilateral adhesive capsulitis on both sides. Man, yeah, that stinks. You gotta wonder what's going on systemically, right? If they've had such an inflammatory process right there. Like, look, not my world, and I don't want to get into that, but that's one of those things where you start talking about like diet or medications, or are they diabetic, like those sorts of things. If you have that, but that's one of those things I would say like, hey, you got to follow up with your PCP. Like, I'm a believer of like functional medicine docs and like those sorts of things. I would say kind of explore some of those things, because that's pretty goofy. Bailey asks, how do you approach nerve issues in the shoulder when strengthening flares up nerve symptoms? Well, you don't want that to happen. So if you're having nerve symptoms, I think you got to find out why. Now with the shoulder, it's usually either cervical spine, obviously, but sometimes it's thoracic outlet related symptoms too, which I think happens more often than we give credit. They're just so subtle, or maybe they're not vascular, so they're obvious. But if you're having some of those like neurogenic pains down your arm, that's not something you want to work through. Now, one thing to keep in mind, it always goes back to this. If you have too much laxity of your shoulder, right, and you're moving your arm in these functional spaces and you have this laxity, you could sublux just a little teeny bit, and that's right where your brachial plexus is. So keep that in mind. You might actually just need a little bit more dynamic stability. Let's see. Julia says, I'm a senior athletic training student. Awesome. You're pursuing physical therapy. Cool. How do you address the stability issues in patients with chronic shoulder subluxations? Do you isolate the little guy muscles first to help control the joint, or do you focus on strength component of the big guys? So no, you don't. And first off, Julia, I love it. You're already starting to use my catchphrases and all my nonsense. That's awesome. So I like it. But yeah, no, you actually don't want to work on the big guys, because the big guys are going to overpower you. You're going to do too much with that. So with somebody with chronic shoulder subluxations and instability, you have to get their rotator cuff and scap strong, like as strong as you can. So go back to this analogy: static stability, dynamic stability, right? If your static stability sucks, you need the world's best dynamic stability. Does that make sense? So you got to get that as strong as you can and as stable as you can, and just go boom, boom, boom. Right? That's important thing. So if they're coming to you for treatments, that's not the person you're wasting time with. They're not on the arm bike. They're not like even doing some of the basic exercises. They're there to see you for your manual strengthening and dynamic stabilization drills. Those are huge for you. Let's see. Orion says, in my experience, have you found an association between baseball players' lack of thoracic, pelvic, or hip rotation and shoulder injury or pain? So believe it or not, so I measure everything, right? We do a ton of stuff. I've been measuring stuff in baseball players for over 20 years now. We stopped emphasizing the hip as much because things just weren't correlating as much as we wanted them to. I don't think the hip correlates as much to shoulder pain as we think it does to shoulder dysfunction. Now, that's not saying that hip mobility is not important for an overhead athlete, but I don't think it's related to pain as much as we do. You could do like a big systemic review and try to find like a couple of things like that, but I don't think it correlates as much as you want. But here's the big issue with most baseball research. So the first thing, I do two things when I read any baseball research project. I go right to the methods. The first thing, if they don't break out lefties and righties, I almost don't read the rest of the paper. Lefties are weird. You're weird. I can see all you lefties all thinking, yep, those ones. Yep, exactly. Lefties are weird, right? We're not supposed to be lefty. We're all kind of righty, right? Your heart's over here. Your liver's over here. We're all righty, right? Like, but why do some people want to use their left hand, right? So the left and the right are different. Lefties still tend to have less external rotation. You have more external rotation on the right. I don't want to get too deep into it, but trust me, they're different. So lefties and righties are different, right? You gotta keep that in mind. So let me see. What's my favorite technique for decreasing inflammation? Drugs. No, probably though. Probably anti-inflammatory medications, a cortisone injection or something like that. But remember, I'm the sports medicine guy, right? So like, I want you to play tonight, so we're going to give you a cortisone injection, right? But for me, for the techniques for inflammation and modulating pain, we do stuff like laser. We'll do things like ultrasound at time if that's what they need. And we do stuff like Voltaren cream or whatever it may be based on that person. But for me, it's oftentimes we have to figure out why you're having that pain and inflammation. And it's oftentimes that you're picking some scab. Right. And I think that's the big thing is stop doing what you're doing. You're either too loose, too tight, or you don't have good control. And then you keep irritating your rotator cuff. You're doing the same thing over and over again. So of course you still hurt. Right. So I can treat the pain all day. I'm wasting my time if we don't figure out the why, if that makes sense. Let's see. Vince wants to know why, wants me to explain a little bit more why I do soft tissue before joint. If the reason why you lost your motion is because of soft tissue restrictions and you start torquing the joint, you just made a very hypermobile joint more hypermobile. Does that make sense? And that's not what we want. The majority of the time, I find that as problems. Baseball players doing sleeper stretch and torquing the joint, posterior capsular mobility. They'll go to PT someplace else for like 12 weeks, for like 16 weeks or something like that, and almost get worse. Don't get better. They come to us. It's addition by subtraction. We stop doing the torque on the joint and we work on the soft tissue, and they're magically better. And we look like geniuses or genii. I don't know what that word is there. Geniuses? That doesn't sound right, but you know what I'm saying. We look smart, right? Even though I'm clearly not that smart. What is my go-to tissue to release for external rotation restriction at 90-90? Go lat and teres major. Okay, Amy, that's a good one. Lat, teres major. Sometimes subscap. Okay. And if it's an overhead athlete too, subscap more than you think. Kristen asks, what's your approach for calcific bursitis? That is a little bit more specific. Patients had pain for 4 months, gone through 2 other PT clinics, can't tolerate anything more than light isometrics. Ugh. Uh, sounds like a good one for the student. Let me see here. That's a tough one there. If they've had pain for 4 months, have gone to 2 other PT clinics, and they can't tolerate much more than isometrics, the first thing I would say is strength is not the focus right here. You have to make sure their mobility, remember that big key we said right there, I bet their mobility is a little bit off. I want you to really work on that mobility first. You might be doing too much, even if it's isometrics, that it's keeping it irritated. And that's why I said before, if you have a mobility restriction, don't go past that. But I hate to say it, if it's 4 months, 2 other PT clinics and isometrics hurt, it might be time for surgery. So I hate to say that. So Brian says, thanks. You got it, buddy. Aaron says, how many reps per exercise do you like to shoot for? It varies. I actually do some fairly complicated periodization schemes, way beyond the big part of this. We talk about this actually in like my champion performance program, but like, yes, I'll start 2 sets of 10 and we'll do a linear loading progression for a long time until you max out, but then we'll manipulate the set rep schemes and do some periodization. So that way we can get some fancy stuff going if we need to. So for the shoulder, I'll do things like pause sets. I'll do things like, like 4 sets of 5 and go up in the weight. There's only one thing I don't do. Right. And I could probably said this was like the 6th key. I should add a key next time I do this. Right. Is we never, ever, ever work the cuff to failure. Right. The cuff is a postural muscle. Right. So your quad, right, it sits there all day and just hangs out. And then all of a sudden goes, boom, kicks. Right. That's your quad. So it's just sitting there hanging out and then boom, I need to explode. Your rotator cuff, your neck muscles, your back muscles, right, they're on at a small percentage of MVIC, like that max voluntary contraction. They're on throughout the day, just stabilizing. Right. And they're always, if I go to move my arm and my rotator cuff's not there because I fatigued it out in an exercise, then they're going to get superior humeral migration. And that's going to cause all those issues we just talked about. So be careful of that. So Rochelle asks, how do you address clicking in the shoulder? I usually ignore it. Oftentimes it is the AC joint. The majority of people, 90% of people have AC joint osteoarthritis in their 20s. You can use that stat for your next social gathering. Not that we can have social gatherings right now, but you know what I mean. But osteoarthritis of your AC joint. Oftentimes we ignore that. Sometimes the clicking's from the labrum, the capsule, that's different, but you should be able to figure that out. Ruben asks, what's my thoughts on the SFMA to help diagnose mobility versus motor control? I think it's actually much more simple than that. I think what we just talked about is even a little bit more simple. I'm a fan of the SFMA, though. I do appreciate it, but I don't think you need to even do that. I think you should be able to figure that out pretty easy. Let's see, Saker, I don't know if I'm saying that well, but sorry, Saker. What are some techniques used to restore periscapular muscle balance in patients with dyskinesia? So if you have dyskinesia, the first thing we have to do again is just make sure it's not nerve related. And if you do just have some winging in there, it's oftentimes just a control issue that you don't have enough strength in there. So usually the first thing we do is just our scap muscles. And I hate to say it, it's the plain, boring prone exercises like Ys and Ts and stuff like that. Yeah, look, we can all go on Instagram and say that those are stupid and boring, but those are the foundation. You have to do those exercises, right? I'm the advanced guy, right? That's what you all like perceive me as, like on social media. I do the fun, cool exercises, right? I'm telling you, those are the exercises you should be focused on. Side lying external rotation, right? If I was stuck on an island and I only had one exercise I could do, side lying external rotation. I don't know why I'd be limited to one exercise on an island, but that would be the exercise I would probably do. Let me see. Victoria says, what do you think of lateral discrimination and graded motor imagery training of the shoulder? Oof, you got me. I don't know. I think that's a little bit beyond me. I'm a little bit more biomechanical, obviously, which I think you can tell. I think there's more to pain and there's more to orthopedics than just biomechanics, but I do think the shoulder is quite mechanical, right? And that's kind of the basis behind all those things we taught. I've been fairly successful, I think, in my career working with shoulder patients, focusing on those things we talked about in this presentation. So I think all that stuff is great. I don't know. You said specifically using like motor imagery training with frozen shoulder. I don't know. If you have a mobility restriction, I think it's more than just doing some of that stuff, if that makes sense. Those working together, though, I'm all for it. I think that's cool. Let me see. Ashley says, what's my go-to exercise for low trap to avoid excessive upper trap? I like it, Ashley. That is a very good question. Thank you. Wave your hand if you're on camera so I can just see that you're cool. But awesome. Yeah. So a very good exercise. You want to get low trap with as little upper trap as you can. I think that's really smart of you. So there are some exercises. So low trap actually can get some upper trap in there. The one I would probably go to most is the W, right? Because a W actually takes some tension off that upper trap. Read my article from JOSPT. I don't even remember what year, but I have an article on my like overview of all the exercises for the shoulder and scap, and we talk about that quite a bit on that ratio in there, and I go through the whole spectrum of them. But you said I only had to pick one, so if I have to pick one, it's the shoulder W. Let me see. Dennis, like, good one for the student. I like it, Dennis. Let me see. Liz asks, what's the biggest culprit you've observed for chronic supraspinatus tendinosis in pitchers? So you set me up, Liz, and I already kind of told you this. So she says, what's the biggest culprit you've observed for chronic supraspinatus tendinosis in pitchers? Biggest culprit is pitching. That's it, right? If you want your shoulder to stop hurting, stop pitching, right? No, but honestly, when you tend to get supraspinatus tendinosis, that means it's chronic and degenerative. You probably have an older individual in their 30s or something. If they're in their 20s, it's not supraspinatus tendinosis. You get a whole nother issue that you're dealing with. But like, let's see. Rochelle says, "Thanks for news. You seem very nice." You never know. You never really know. You can't tell over a webinar. Let me see. Amy says, what other small rotator cuff exercises besides side lying ER and manual resistance do you go to? Side lying ER is big. I do the progression though at 45 and 90 degrees of external and internal rotation because it gets the different muscles slightly differently. But we do that. We do Fulcan. We do prone exercises like T's and Y's, prone external rotation. Those are still the bread and butter. Those are the big ones you still have to do. Resist the urge that you're seeing on Instagram to get fancier. Do that first. When you get good, then progress. You put those together, you'll have outstanding results, I promise you. Let's see. Tyler says, thanks. Trevor says, when do you think it's appropriate to incorporate e-stim or biofeedback into shoulder rehab? I love it. That's good stuff. For some reason, nobody does neuromuscular stim on the shoulder, right? How many people do neuromuscular stim on the shoulder? A couple people. Good. That's actually pretty good. So we were like mad, like, I don't know, this is like maybe like 15 years ago. I don't remember what year we published, maybe 2009 or something like that. We published a study on neuromuscular stim on the rotator cuff after rotator cuff repair. Because we were like, wait, why is everybody doing it on ACLs and total knees, but nobody's doing it on the shoulder? So we do it all the time with post-op for neuromuscular stim. So biofeedback, e-stim, posterior rotator cuff. Yes, we do that all the time with our post-ops. That's good. Trevor, second question says, what's my thoughts on BFR for shoulder rehab? So, believe it or not, I don't use blood flow restriction training for the upper extremity a ton. Now, I have a few different reasons. And I'm actually in the process. We're actually building out a course with my friend Dan Lorenz. We're going to be launching a BFR course and how we use it pretty soon in the next couple of months. It's going to be pretty cool because it's how we clinically use it. But I don't use it a lot in the upper body. Couple reasons. Reason number one, I work with a lot of baseball players. I think they all have neurovascular issues right here just from throwing. I don't want to compress that. But two, I don't have trouble getting people's shoulders strong. Like, do you guys? Maybe you do. That's why you're on the webinar, right? But you won't after tonight, right? Like, I don't have trouble getting people's shoulders strong. I don't need BFR to help me with that. And I think the proximal above the cuff benefit of BFR on the rotator cuff is probably small anyway. So I don't use it as much. I use it on the legs a ton. We do it a lot of our post-op patients. If it's an upper extremity post-operative patient, we may have them like ride a bike with it on just to get like the systemic response, the growth hormone release, then we may do that. But to actually do it on the arm to say like I'm trying to get the rotator cuff stronger, I think I don't do that a bunch, to be honest with you. Let me see. Thoughts on strengthening upper trap versus lower trap since they're innervated by the same nerve. Yeah, no, upper trap's gigantic, right? So you can definitely do an exercise that gets more of a balance on those muscles. And there's tons of EMG studies that show that you can differentiate that with the same thing. W and prone, you can do like external rotation prone, yeah. Let me see. Haley says, as a junior AT student who just learned about the shoulder, nice, you sold me on your program. I wasn't, I apologize. Amazing teaching ability and explanations. I'm going to show my preference. Okay, good. Sorry. I thought you had a question. Thank you, Haley. I appreciate it. Gwendolyn asks, oh, good. Gwendolyn put the, the full reference of that article I was doing. See, Gwendolyn's smarter than me, right? She already jumped on and got that going. But if you want to look in the chat thing, you can, there's the reference to the JOSPT article. Looks like it was 2009. Let me see. Deborah asks, it looks like we only have a couple more. So I guess like last call if you have any questions. But Deborah asks, do you ever use electrical stimulation or ultrasound? I do. It's not something we use a ton, to be honest with you. For e-stim, again, we'll use the neuromuscular stim when somebody's having trouble with volitional control, especially like after a surgery. So we do that. Stuff like a TENS or something like that. I mean, if I'm trying to just neuromodulate pain for somebody that's like an acute spasm or something like that, then yeah, I'll do like a TENS based thing. Ultrasound for the shoulder, not a ton. I mean, there's some studies out there that show that ultrasound helps with like ligament healing and stuff like that. So like, again, it's one of those things that's completely shunned on social media, but we use stuff like if you come to me with a Tommy John, you have a partial UCL reconstruction, I am going to throw the kitchen sink at you. I'll rub chicken bones on you. Anything we can do to try to get you to not have surgery is fine. So doing like a pulse ultrasound on top of the ligament and not moving it, keeping it there for like a good like 8, 9, 10 minutes has been shown to actually help some partial ligaments to heal. So of course we're going to do that. So yes, we definitely do that. Aaron says, do I use the Mark Pro? I personally use the Compex by DonJoy. That's a very similar device. It's a lot cheaper and does a lot more. So I personally prefer that. That would be what I would say. Ian says, notice you did not include dry needling. I do dry needle. I am fine with dry needling. Dry needling, I think we don't do it like on everybody all the time, but we definitely do it. For somebody where like when you palpate the muscle and the muscle feels like super tense, right? So upper trap, teres major seems to be like a good one sometimes when you can actually like feel it. Like I often tell the students when we're working on like teres major, I want teres major to feel like a strip of like beef jerky. Right? I know that kind of sounds weird, but I want it to be beef jerky. If it feels like a big, like Crayola magic marker, then that's a big, dense teres major. And then what we do is we'll go in there. You can dry needle the teres major, and you get a couple of fasciculations, it'll like twitch a little bit, and then all of a sudden it feels more like a beef jerky. I don't know why. I don't know what the heck it's doing. I'll be honest with you, but wow, it's important. I like that. For anyone that dry needles, you've probably experienced this too. Who am I to judge? And I think it's very, very hard for us to do a lot of research on a lot of this stuff because it's very hard to control this in humans. But how many times have you dry needled somebody and then 3 hours later they text you and they say, OMG, my neck feels amazing. I don't know what you did. Thank you. Have they ever done that after an ultrasound? Right? No, right? But they say that after dry needling quite a bit. So I use dry needling at times, usually for certain muscle groups that I feel are dense or really like very like contracted, very like almost like sitting in some density, and then get that to relax. And I just think it helps reduce the tone a little bit better. But then I'll superimpose all other techniques, if that makes sense. Thomas asked about K-tape. There are some studies that show kinesiology tape helps people feel better and move better. And if you put it on, their biomechanics change, the kinematics of their scapular changes, and they have less pain. I gotta say though, I don't use it. And the reason why I don't use it is I've tried it quite a bunch over my career where you're like struggling, and I never got like good enough results. And just like what I kind of said before with that text message, nobody's ever said to me like, OMG, that feels amazing after you did that K-tape. So it's one of those things like I've tried, but I haven't really done it. I can't explain the physiological rationale behind it either. And that's something with me. I need to kind of feel like I get it. Like that density with the dry needling thing. I'm not 100% sure why it does it, but it clicks in my head a little bit. When you have that really tense upper trap, you dry needle it, you get it to twitch real fast, and then it relaxes. I get it. I see what it's doing. I don't get K-tape, if that makes sense. So Thomas says, tell that to my high school kids. I assume you're talking about that K-tape. Let me see. Amy asked, to stop scapular winging, are you targeting more cuff or serratus? Not so much cuff. The cuff, you probably wouldn't get scapular winging because of the cuff. It's probably serratus and low trap would be the two big ones that I do. She says, for somebody with chronic subluxation who can't have surgery till their winging's better. Yeah, I think the doc just wants them to be stronger then would be my guess. They'd probably just have like a really weak scap. So they probably gonna get stronger with their rotator cuff. That's probably like a young, loose person if I had to guess. Let me see. Lynn says, what are my go-to return to play testing for upper extremity injuries? So believe it or not, we don't use a ton, and there aren't a lot of good ones. There aren't any that have been validated very well. There's a bunch we've tried. So George Davies has published a bunch of good ones. Kevin Wilkes trying to do some ones there. Yeah, Amy said, yep, 13-year-old gymnast. Yeah, no chance. 13-year-old gymnast. You're that's one of the hardest patients in the world. Yeah, but no, a lot of people have tried to do return to play testing. They're super hard to do for upper extremity. And believe it or not, I think we're finding out they don't really do much with the lower extremity either. They're actually not as valid as we think they are. So we're kind of in this weird jam with return to play testing that we're not quite there. For me, I hate to say this because it feels like a cop out, but if you've gone through my rehab progression, that's my return to play testing, because I know everything is an advancement of that. Before you can pick up a ball and throw it, if it's a shoulder injury, you had to have gone through your one hand plyos. In order to be able to do your one hand plyos, you had to do the two hand plyos. In order to do the two hand plyos, you had to have good baseline strength of your cuff and your scap. In order to do that, you had to have good dynamic stability of your cuff and your scap. If you can do my exercises that I'm doing with you, then throwing a baseball 60 feet, like at the beginning of a throwing program, is going to be boring. It's going to be anticlimactic. That's what I want. So that's my return to play testing, is that my manual techniques that I'm doing, I'm sure that they're going to do even better because it's going to get boring, if that makes sense. Awesome. Man, you guys asked some good questions. That was impressive. What do you guys think? That was helpful. I see some thumbs up. Was that cool? So if you think about it, right, those 5 keys it's not rocket science, right? I don't think any of you are just like, wow, I never really thought of that. But it's when you put them all together and you kind of frame it together. That's a big thing with how I kind of like teach some of my things. It's about how you put it together. Okay, so keep that in mind with those keys there. If you focus on all those things and you truly understand the dynamics behind it, I think you'll do a much better job with shoulder people, and it's a little less intimidating, right? It's not as overwhelming because you realize if you stick to those basic principles, you're going to hit a home run like 80% of the time. It's pretty good, right? And if you miss on that person, it's usually because they have something big going on. Maybe they have like cuff tear or a capsule tear, or they have like a full-blown adhesive capsulitis. Yeah, that's something different, right? But for those people, shoulder pain, if you focus on all those things, I promise you're going to have much, much better outcomes. You're going to be impressed with just those little things. So think about this. I want you to go tomorrow. Tomorrow's Tuesday, right? It's the middle of the work week, right? I want you to start going through some of these things in your head. I want you to think about the anatomy. I want you to think about the mechanics we talked about with that next person. I want you to think about static and dynamic stability. Okay. Do they have good static stability? Is it hypo, hyper, right? Do they have good dynamic stability? And then that is going to be your focus. If they're tight, you have to work on that first. Soft tissue before capsule. Then you have to work on control, isolated strength, dynamic stability. I hate to oversimplify it, but it's kind of that easy. It just takes time to click. Make sense? Awesome. Again, thank you, everybody. That was awesome. It was a good couple hours that we did this. I appreciate everybody taking time out of their evening to do this. This was fun. I love teaching like this. Again, if you're interested more on the shoulder, trust me, you'll love that course. The course is super detailed. It goes over all this awesome stuff, but like tells you all the specifics, everything that you might want to know. So check it out if you want. Not a big deal if you don't. I think even just the information that you learned from tonight will be super, super impactful. So again, thank you very much. I appreciate it. Thank you for attending. Thank you for following me online. Thank you for checking out my blog, my podcast, and keep in touch. If you need anything, send me messages. I've probably gotten back to a bunch of you guys already. I'm a real human, right? Like I don't have like a big resource department that's helping. I'm happy to help. So if you have questions, let me know. And hopefully I'll see you guys on the next webinar. Okay. Take care. Stay safe, everybody.